Thanks everybody for being here. Today we have the pleasure of listening to Dr. Adam Kanter speak on evolution of the minimally invasive spine surgery, the lateral access and deformity. I've had the pleasure of knowing Dr. Kanter since I was a sub-I in neurosurgery, and he was a junior resident. And I've been trailing behind him ever since as he's risen up through the ranks of neurosurgery. Being a associate professor at Pittsburgh, as well as a co-director of the fellowship program there, and now chief of spinal surgery at UPMC. He's well known for his work on lateral approaches to the spine, and it's been really at the forefront of deformity in spine, ALL release, and he's recognized as a world expert on lateral access. So we appreciate having you here, Adam, and we look forward to listening to it.
Great, thank you, Kai. Thanks to Rupa for reaching out. Thank you, Kai. Thank you, Dr. Hartle, for setting the stage for us all to continue this work. So, and thank you all for being there and listening this morning. I appreciate it. I'm going to talk to you about the evolution in minimally invasive spine surgery, particularly in relation to lateral access and deformity. And please feel free, if folks have questions or concerns or want to chat in the middle, feel free to just speak up. Hopefully, every now and then I'll check in, make sure you guys can hear me, make sure I'm not just talking to the screen here. These are my disclosures. Everybody hear me okay?
Yep, sounds great.
Yeah,
okay.
Sounds good.
All right. More importantly than these disclosures are these ones, though. So for you New Yorkers, I'm from Boston. I was born there, or I'm sorry, I was raised there. I was married there, and I wrestle just south of Boston in Brockton, Massachusetts. You're going to see some wrestling throughout this. It's a passion of mine with my kids, and I'm a New England fan. Again, for you New Yorkers, I remember what you guys did to us in Super Bowl 42. I remember the ending there, Super Bowl 46. I remember that ending. I was actually there with my son. We've been very upset about that. So not a huge fan of New York, but I did, Kai again, and Kai and I trained together. I was a senior resident when Kai was my junior. We trained at UVA, the University of Virginia, and we trained under Dr. Jane, who taught us not only how to operate and how to be leaders, but how to always be there for each other. And when you do that, when you do things like this was one of our graduation photos. There's Kai right in the background. But more importantly, actually more relevant, is when I went away to New Zealand for our externship in 2005, I came back, and Dr. Fu taught me how to drop my first set of tubes. That actually sounds inappropriate when I say it out loud, but when I came back, Kai said that he learned how to perform some MIS surgery with this metric system, and he showed me how to do it. And from there I was hooked. So Kai, thanks for my introduction to MIS spine surgery. And I continued that on. I went and trained at UCSF with Praveen Mumanetti. You can see this is in 2008. And we learned how to, or he taught me how to continue to turn pictures like on the left there in traditional surgery into the right side and perform less invasive interventions. I then continued on, and I've been at UPMC ever since. So see if I can move my thing here, get that out of the way. All right, so I've been here at UPMC since January of 2008. Sorry, you guys still see this?
Yep.
I'm trying to eliminate the bar at the top. I'll just move it.
Looks fine, no bar.
Okay.
We don't see a bar. I think.
All right, good. Perfect. Well, since I've been here, I've been doing my best to continue to use lateral as my primary workhorse. Of course, it's just a tool in my belt, and I think that's the general rule here. Is I want to relay is what I'm not trying to suggest is that every case out there is appropriate, particularly with deformity, for incorporation of lateral access interventions. But it's important to have that within your armamentarium, within your tool belt. And it's interesting, when I spoke with Kai earlier, I asked how many of the spine surgeons there are performing lateral, and his response was pretty much all of them, which is amazing, because years back that was not the case at all. In fact, when I got here, I was the only one. That was performing it, and oftentimes, still today, when I give lectures or perform these visiting professorships, I'm often the only one in the room that's performing lateral. So I think it's fantastic for the residents there that you guys are getting this experience where you have this tool in your belt, and it allows you to really either utilize it when appropriate, utilize it more often than others. Some people are very comfortable with it, some people less, but the fact is, if you've been trained on it and you have it in your tool belt, you can make the best decisions for your patients. Here's when we started incorporating it for expanding its indications, right? So we were performing it for far lateral disc herniations, and it's all of a sudden everybody heard, not a lot of folks aren't big fans of performing far laterals because sometimes patients don't do quite as well, where you end up having to fuse them. And we started using this lateral access to perform these interventions and take out these far lateral discs without fusing them, and then became the experts on that, of course. So let's see, moving on. I'm not going to go through all the clinical indications because you guys have that, right? What we're going to focus mostly on is lateral access in the utility of scoliosis and deformity surgery. And one thing we've learned right from the very start, as you can see from the manipulation of the spine, is that it's an extremely powerful tool. You can truly manipulate the spine in a dramatic way, more so than any other way with any other interbody device. With this single interbody. So it's very dramatic, it's powerful. As you can see in your lateral, you can really expand and distract and get that indirect decompression, opening up the foramen. So utilizing these tools, you can do so through very, very small portals. And that's something that, of course, patients like, and we like as well. But with any spectacular achievement comes unspectacular preparation. And this has taken years and years for us to get where we are today. So I'd like to start off by kind of telling you how we got to where we are, showing you some basic, simple cases, and that we've employed various techniques in the lateral access corridor, and then show you the data stream, which I've been lucky to be a part of the International Spine Study Group, the ISSG, along with Kai Fu, and hopefully I'm going to present some of its data. We have lots and lots and lots of data. I had to delete about half the slides because I don't have 2.5 hours. So hopefully we'll be able to give you a generalized idea about why go about having these less invasive techniques, because systematic reviews have shown that when looking at up to 50 articles, and this is back in 2010, Jim Harrop out in Philly found that nearly half of the patients that had deformity surgery had complications. And the ISSG performed a series looking at 953 consecutive patients, and found that the patients that had the complications, when you compare those that had complications to those that did not, the major complications appear to be more related to the procedural variables than to the patient variables, which is very, very interesting. So it's not just the elderly or the sick, with the morbid, it's actually what you do that matters just as much as who you're doing it upon. And we published our initial series back in 2010 in Pittsburgh after performing deformity with lateral for the first couple of years. And I can show you, this is our very first case, and I'm hoping the video shows. This was my very first lateral access procedure. We actually did it in a deformity patient. I did 4 levels, and you can see this is a 70-year-old woman that nobody was touching. She had such terrible conditions. She could barely walk again. She was just miserable. Hopefully this is going to play. Yeah. Is that playing?
Yep.
Great. So this is real time. You can see how very quickly I can perform these operations. But again, this was our very, very first one, and I want to show you this so that you can understand how much we've learned since then. Because that was the surgery, very first lateral. You can see the end plates look okay. Maybe here at the top, at the top level, maybe it looks like the end plates, but it's kind of a funky angle. But the end plates at these other look okay. Now these were the 18mm cages, so early on in the process. But so there's post-op day 1. Doesn't look so bad. Looks pretty good. Looks like the foramen are wide open. She looks straightened out. Again, I didn't know to get long cassettes. Back then. This is 2010. Still working our way into that evolution. But things looked okay. But what about at 6 weeks? You can already see these starting to fail. Right. This was an older woman. She was osteoporotic. And again, you might say, well, why not actually incorporate screws? Why not open her up from the back and do hybrid? We were trying to operate on someone that wasn't going to get an operation, who was absolutely miserable. And we thought, well, we've got a technique here that might enable us to give her something. But it turns out that sometimes something is not enough, right? And here we are at a year, and you can see complete essential failure at every level, return of her symptoms, and she ended up needing to go on to have, you can see she's got a green field filter, complications, started to arise, and she ended up having more surgery. But the point of this was to show that we've learned a ton. We've learned a ton. We've learned that standalone in deformity in osteoporotic, elderly, obese patients is probably not going to be a success, an algorithm for success. So with any overnight success comes the recognition, or is simply the sudden recognition of years and years of hard work. And that's what we've done, is we've done years of hard work. And at the start, we first started doing these back in 2008. This was one of our cases, our initial cases. What we began doing actually is opening them up from the back. So performing a hybrid procedure where we started from the back and basically loosened up the spine. So put the screws in, perform some Smith-Peet osteotomies, remove the facets, and tried to create a flexible spine. And when you create a flexible spine, then you can really manipulate a deformed spine. So instead of having to employ techniques where you're really kind of torquing off of the hardware themselves, you can see, you can get pretty dramatic movement, as we showed before, in these deformed spines with incorporating the lateral after you've loosened it up and performed your osteotomies from the back. So we could get really nice corrections with very limited effort by starting from the back and then coming around the side, and that's at 1 year. And we published this series. This was in 2014. We started incorporating PSOs. So again, starting to get more, realize that lordosis is more important. Let's get that lordosis, and oftentimes you need to get the lordosis through the back, right, by the shortening procedure, pedicle subtraction osteotomy, until of course we came out with the ACR. And I think you guys had Rupa and Pimenta that I'm sure have shown the benefits of the ACR. And here's a few cases. This is one where we have a lateral procedure performed both above and below at 2, 3, and 4, 5, and then at 3, 4 came in and performed an anterior lengthening procedure, right? So lengthening as opposed to shortening. And of course, dramatically less blood loss because you're not removing the bone, or at least portions of as much as you need to by performing that. And we started performing these in the lateral anterior position. So we were in the lateral position, we would come from the side, and then we would also come from the front in the same lateral position. And here's an example showing that patients in the lateral position, we would come in and perform the lateral access and then close that wound up, and then have our general surgeon, and unfortunately these ones are not playing. Well, have our general vascular surgery colleague come in, place the condom, expand the canal, and then enable us to advance these anterior column lengthening procedures at L4-5 and L5-S1. Sometimes L4-5 we could just get laterally, but if not, we would do it from the front. So now we're incorporating these large wedged triangular grafts from the front at 4-5, at 5-1, and we're able to get pretty dramatic restoration of lordosis without having to actually perform the posterior procedure at this point. So now you can see this is a patient that has had the lateral access as well as the anterior access while in the lateral procedure. So this is pre-op, this is post-ACR. So you can see the dramatic restoration in both coronal and sagittal plane. This patient doesn't have a single screw placed from the back yet, right? There's one screw that was placed laterally to hold in the ACR, but you can see dramatic restoration of lordosis as well as improvement in SVA without any posterior hardware, right? And then the posterior hardware can be placed oftentimes in a less invasive fashion as well. Here's our post-op. You can see here's another patient. Patient doesn't have to be naive to surgery. This is a patient that had previous attempt at correction low down. You can see significant SVA imbalance still. Performed an ACR above the previous hardware. And you can see the restoration of lordosis at that level. Again, in the lateral position, performed a single level A-lift below. So now here, this is pre-op, this is post-ACR, here at 2-3 as well as at 5-1. You can see the patient's SVA is dramatically improved, and then when locked down, gets it to within normal levels, and with a PILL of less than 10 at this point. So a very, very powerful procedure, being able to perform lateral access interventions. This is when we started performing lateral posterior in line with lateral XLIFs or lateral interbody fusion. So we would start from the back, and this enabled us to actually work together. So Dr. Okonkwo, who is one of my partners and also trained at UVA as well with Kai and I, he would come from the back while I was doing the side. So at the same time, we would be performing posterior during lateral access. You can see my lateral is already in, and he's advancing the screws. Now this case in particular is not a deformity. This is one that we were performing together, but this is where we started, right? Start small and then grow from there. And this was our patient. You can see, a larger patient had a fusion through, 2 Band-Aid incisions, right? That's Dr. Okonkwo. That's me at the top here performing the lateral, and Dr. Okonkwo coming from the side. Now, more recently, as Dr. Hartle just asked, hopefully you'll see if these can play a little bit. This was us performing the prone, so lateral in the prone position. And this we found to be, sounds like you guys just had Dr. Pimenta there pushing this. This is, I would say, very awkward to perform. And again, we're early on in the process, but it just, a lot of the procedure itself, the muscles that you're using to perform the operation are unique, and your muscles can tire quite quickly when performing these operations. But the tools that we currently have, the tools are made to be performed with the procedure in the lateral position, not necessarily in the prone position. And that's something, again, as we're going to continue the evolution of the procedure, if prone lateral is really the way that we're going to go, and some folks are really pushing it, and finding it's a lot of people are much more comfortable performing lateral in the prone position, simply because they've been trained in the prone position. Folks like yourselves, the residents coming out of Cornell, you guys are going to be adept at both, possibly, if your faculty do incorporate it, and I suspect, I'm sure they will. But again, it's a very awkward performing procedures, not only because, for over a decade, we've been performing in the lateral position, but simply because of the tools that currently exist and the manner in which the procedure is performed. And so hopefully I can kind of, it doesn't look like that one's going to play. Let's see if these are some of the positions. Here you can see you're sitting very, very low on a stool. So your arms are above your head, right? You're working straight across in order to see. It's just very awkward to be looking down. The other thing is you don't have gravity helping you out. You can see as I'm trying to hold this instrument, the muscles that I'm having to use to utilize the cob and perform the end plate takedown. It's not the same. There's the graph that went in, and then in the same position, of course, you can just go ahead and proceed and perform the back. Let's see if these ones can play here. Yeah. So here I'm actually showing this one to show you don't have the use of gravity. Oftentimes your K-wire stays in. Here I'm like stumped, thinking, wait a minute, my K-wire is loose. So you don't have gravity holding your K-wire down and the K-wire release. That's the first time that's happened to me in a decade, and I had to start over again. So let's see, here you can see me using the cob and just the angle that I'm using it at, and how I have to hold the instruments that we currently use in order to, I'm trying to come along the end plate there with the cob. Just very awkward and odd. Not something that can't be overcome, but at this point in time, still struggling to figure out how to do this properly with the tools that we have. And it's going to take a combination of surgeons, obviously, with the companies that are helping to create these tools to do so. And then this is simply showing you can see the lateral incisions open here on the side, at which point we then proceeded to perform the posterior. And one thing to consider is actually, while the lateral is being performed, you can already have one of your partners or residents starting the lateral or starting the posterior from the back, so they can be performed simultaneously. And this was, our first prone XLIF or lateral interbody fusion. You can see the size of the patient. That's one reason that we felt it beneficial. But in fact, the size, usually, I'm perfectly fine operating and performing lateral access surgery on the obese population, after we've done our best, of course, to try and optimize them. But oftentimes the these folks say that they can't do anything, they can't get up, they can't be active because of the severity of their pain, and you're kind of forced to either operate or not. In this situation, lateral has always been a nice workhorse for us, but in the prone position, it was much more difficult actually in the obese patient. And of course, our friends, this is one Uribe's group is starting to write this up here. This was a case report on the technical nuances of performing prone lateral. So that's kind of a very quick kind of run through of how we got to where we are today and the different ways that we're performing lateral access surgery. But, you know, importantly, let's look at the data, right? So we talked about in 2010, we presented our initial series, and one thing that occurred, we had a bowel perforation very early on. So this is catastrophe. This is where you say, all right, this is not safe. This is why a lot of folks actually abandon it quickly, is because they don't want to deal with, you know, such horrific complications. In fact, complications that we as neurosurgeons can't actually even fix, right? We have a bowel problem. We have to bring in one of our colleagues. But, you know, I had a strong chair at the time who told me that failure is not fatal, and, you know, continue on, keep working hard and keep evolving. In 2014, you know, we published our larger series, Radiographic and Clinical Outcomes, incorporating lateral, and we did some very difficult cases, incorporating lateral with our posterior. Most of these were hybrid at the time. You can see here, this is pre-op versus post-op, and at 1 year, our radiographic correction was dramatic and it was sustained out to a year. But most importantly, is we've all learned the importance of pre-op, of your lumbar lordosis and pelvic incidence and getting them to match. You can see here at the top is our lumbar lordosis in the blue and our pelvic incidence in the red. This is pre-op. Down here is post-op, and you can see how we were able to much more closely match them, inducing lordosis to match our pelvic incidence, which dramatically improved our patient outcomes, of course. Now, I know you guys aren't seeing the bar, but it's actually interfering with my ability to read my slide. But here's when we started comparing this is the ISSG group, which Kai Ming Fu was a big part of. This is when we started comparing minimally invasive to the hybrid procedure, which is the lateral access incorporation with posterior open, in addition to the open patients, the traditional open procedures. Because with any new intervention, you have to compare and show that it's at least as good, if not better, hopefully better, but at least as good as the traditional approach. And as we started doing this, we started revealing that we are not as good at obtaining radiographic correction. However, we are quite good at getting strong clinical outcomes, improved clinical outcomes. So you can see the more open the procedure, the more we were able to manipulate the spine. And again, this is early on, we've gotten with additional tools and implants and techniques, we've able to do that. But this is early on, you can see that the more open you were, the more you were able to perform proper corrective measures. However, it didn't necessarily correlate with outcomes. Outcomes, we were finding dramatic improvement in our patients, whether they performed MIS, hybrid, or open. You can see no statistically significant difference. But one place where there was a huge difference is you were 4 times less, or you had 4 times less blood loss with MIS versus hybrid and open. Over 2 liters of blood loss on average in the hybrid and open procedures, less than 500 or approximately 500 cc's. Same thing with transfusions, right? You were 3 or 4 times more likely to need a transfusion if you had an open procedure. And complications, you were 3 times more likely to have a complication, a major complication, I should say, with open in comparison to MIS. Yep. I'm not advancing here. Yep. Can you still hear me?
Yep.
Sorry, having a little struggle. Back up one more. All right, when we looked at complications, again, comparing these various MIS hybrid and open procedures, if you look at intraoperative complications, you can see that there was essentially no complications intraoperatively during the MIS, whereas 1/4 of the patients having open were having complications. That's actually a low number. But if you look at post-op, you can see that 30% of the MIS folks had complications. And a lot of that was related to the fact that patients were waking up with hip flexor weakness or with neuropraxias on the side that you went in on because of nerve stretch. And so we, of course, need to look at this and try and determine what this issue is from. And it's not only from, opening of the muscle itself, but it's from stretch. And what we found is that the longer you're in there, the longer you're stretching a nerve, that the more likely it is that you're going to have this neuropraxia. So the quicker we can get in and out, the better. When we look at the ability of our radiographic correction, what we found is that with standalone, so with true MIS, we can only correct the spine about 23 degrees or so, but you can get, and with a hybrid procedure, you can get about 34 degrees of correction. With an open procedure, you can get about 45 to 50 degrees of correction. So the more you open, again, the more correction we're getting. And this enabled us to put together the deformity algorithm with which Dr. Fu was hugely championing for us, and was able to basically put together this algorithm that told us that depending on how much correction you need or how much pathology there is at the start would determine how minimally invasive your procedure can be. Of course, this isn't good enough, right? As we all know, that you need to press on and figure out better ways of doing these procedures. And that, again, encouraged us to continue working to employ these strategies. And we looked at our MIS in a circumferential fashion and compared. You can see on the left, it's circumferential MIS versus hybrid. And what we found here is that both hybrid and circumferential MIS approaches resulted in strong clinical outcomes, but the hybrid group was able to get greater improvements. However, it was at a cost, and that cost was increased complications. So again, the more you open, the more you can correct, but the more you open, the more complications you have. Here, what we wanted to do is look at our best versus our worst clinical outcomes. So the patients that had the absolute best, the top 20% of our patients that had improvement versus the patients that had the least amount of improvement. And what was shown is that SVA is important. The patients that had the most improved SVA and PILL mismatch improvement, those were the ones that actually did the best, right? Compared to the folks that didn't have the best, the improvements in those actually did much worse. So these are important. It's not just well, let's get good short-term clinical outcomes. Of course, we're looking for the long-term here, and in order to get long-term improvements, you need to correct many of these parameters. But that's not always the case. In the elderly, we found out that turns out that you can get meaningful clinical improvement in patients. In fact, in the majority of our patients, with only modest correction in their deformity parameters. And we realized that not everybody needs, correction of their PIL mismatch to be within 10 degrees or their SVA to be, within 10. So we're starting to learn that there's different populations that can benefit to different degrees. And this similarly goes with the obese patients, obese and non-obese, right? Oftentimes it's difficult. You can see here's the demographics of these folks. The only difference being their BMI. And you can see that complications, really, there was no significantly different. So no significant difference. We know that the obese population that have deformity correction traditionally oftentimes have dramatically more complications. That didn't appear to be the case in the obese population undergoing MIS deformity surgery. And the clinical outcomes were strong. Well, what about, oftentimes your hospital systems are worried about the money, right? Is it costing more money? We did a cost effectiveness comparison comparing those that had employment of lateral to those that had posterior and TLIF, and found that when we looked at all the variables, and when I mean all the variables, I'm talking about looking at the costs from top to bottom, including outpatient, the pre-op diagnostics, the use of the anesthesia, the cost of the interbody devices. It turns out that cost effectiveness is not an area where MIS actually is better. In fact, oftentimes it could be more expensive, but that's because you're paying a premium for a lot of these less invasive interbody devices. And that's changing, of course, as they're becoming more commoditized. Reoperation rates, this is something that Dr. Hamilton, one of our partners here at Pitt, and also one of the folks that Kai and I trained with at UVA, he championed this effort looking at reoperation rates in minimally invasive versus hybrid versus open. And you can see dramatic different complications, right? The more open you get, the more complications you're going to have. And not only that, but the higher the reoperation rate. So when we look additionally, complications, you can see no significant difference in outcomes. Minor complications, there's a significant difference when we compare hybrid to MIS surgery. Neurological complications, a significant difference. And of course, operative complications. So we're seeing that MIS decreases complications. If you want to get the correction, the larger correction, and you want to do more open procedures, you have to do it at that risk, and it's simply pros and cons. This is one of the something I was very interested in is working in the concavity versus the convexity. So I'd be interested in hearing what Kai and Dr. Hartle and others have to say about whether you folks often work in the concavity versus the convexity of the curve. I initially worked within the concavity because I wanted to get every level I could in a deformity through a single incision. So I could get 4 or 5 levels through a single incision and kind of, pound my chest and say, look what we can do. This is amazing, through a single incision. But sometimes it was a struggle to get to work through that concavity, to work through those osteophytes, to having to work through around those nerves that were basically kind of kinking, right in your surgical corridor. So oftentimes now I'll work from the convexity and I'll perform one incision on the convexity, and then for the fractional curve, for the lower, 4 or 5, oftentimes I'll end up coming from the other side. Now, especially as we work and perform more of these in the prone position, it's a lot easier to simply choose which side you want to come from. If you want to perform an incision on either side, you can quite easily do so. So there's the concavity versus convexity. And what we found when we compared the two is that clinical outcomes improved regardless of which side. However, in cases where L4-5 was in the primary curve, approaching it from the concavity may be associated with higher complication rates. And I believe it's related to what happens to the nerve, the femoral nerve in particular, within the concavity. And then, of course, anterior column release came into play. And this is about 5 or 6 years ago, where we started performing anterior lengthening procedures, as I showed initially. And we created a classification scheme similar to that, and in conjunction with the Schwab modifier, showing that, as you work your way from grade 1 to grade 5 ACR classifications, you remove more and more bones. So in grade 1s, there's really no significant posterior osteotomies. As a 2, you remove the inferior facet. 3 is total vasectomies. Grade 4 is you're performing PCRs and PCOs, and grade 5 are VCRs. So this was a way for us to talk consistently about what it is that we're doing, and to be able to do so with a consistent vocabulary, similar as with any classification can provide. So what about the realignment? We looked at patients and tried to determine whether or not aligning them was, how important aligning them was. I'm having a little failure of, give it 1 second. It seems like every time I touch the mouse, it stalls on me. Last time it's restarted itself, so we'll give it a second. And now it's gonna fly through, I'm sure. So this paper, this one is on now, was looking at PJK as we started incorporating ACR. And oftentimes, remember where the primary lordosis occurs in the lumbar spine down low, right? But when we're incorporating ACR, oftentimes we were having to do so higher up because it's very difficult in certain situations to perform at 3-4. But it's moving along here on its own now. Very difficult to perform ACR at 3-4, so oftentimes, or 4-5, so oftentimes we were having to do it higher up, more typically at 3-4, but sometimes even at 2-3. So the question became, well, now that we're performing lordosis at a kind of a non, biologic level, meaning that not where we naturally have most of our lordosis, is that going to then result in more proximal junctional failure? And the answer is that if the more posterior osteotomies you perform, the more likely you are going to have proximal junctional failure. It didn't have to do with performing the ACR and the anterior lengthening procedure in itself. So that was good news. The impact of age and alignment. As we looked at these folks, the patients that were older versus those that were younger, again, we pointed at we're showing that these patients didn't need to be as aligned as they did in their elder stages as they did when they were younger. So it's very important with younger patients to make sure they're more aligned in order to get better outcomes. In the elderly, not as big of a deal. And this made our elderly friends very happy. the learning curve, right? So what we wanted to do is look and see when we first started performing these procedures back in 2008, and how over the first 7 or 8 years, how we fared, and what we were learning, and what we looked at when we looked at our clinical and radiographic outcomes from 2008 to 2015, when we look at our complication rate, our surgical and postoperative complications, when we looked at, the number of interbodies used in the procedure itself, you can see the interbody fusions, we went from, on average performing 4 down to nearly 2. So we're cutting the amount of interbodies we're using because we're performing more ACRs, we're getting more lordosis with smaller constructs. So as we've gone through this, we've learned that through this time, there's been a trend towards treating increasingly morbid elderly patients with larger BMIs. We've seen an increasing emphasis on SVA and less of an emphasis on coronal correction. We've seen meaningful improvements in our clinical outcomes with no statistically significant increase or decline, meaning that we've gotten good results from the start, and we continue to get them even as we change and employ new techniques. Our major complication rates started and remain low. However, our minor complication rates have essentially been cut in half. Operative time has essentially been cut in half over that 8-year period. And we've seen a marked decrease in the number of interbodies treated while obtaining higher degrees of sagittal correction using more selective and powerful interbody techniques, including the ACR. So in conclusion, the use of minimally invasive techniques for deformity has evolved over the past decade. Experienced surgeons are treating older, more morbid patients with similar outcomes and increased reliance on selective, powerful tools and techniques. And these, in combination with improved real-time navigation, monitoring, and robotic assistance, is going to continue to help us advance in the utilization of these techniques. And again, the goal here was not to basically say that everyone should be performing lateral on every case. The goal here is to state that this is a powerful tool in your tool belt, and if you can use it when appropriate, you're going to be capable of continuing to help change the way we help these patients. And I'll leave you with the first period is won by the best technician. So there's 3 periods in a wrestling match. We got to be strong technicians. We have to be in shape, right? We have to be able to do what we do, but you win by having the largest heart. And I know Brady's no longer at in Boston, but ultimately in the end we win. So hopefully, I think I finished on time for the first time in the history of my career. So open to have any questions. Thank you guys. Thanks for listening.
Great, thanks, Adam. Yeah, we'll open it up to questions.
Hey, Adam, it's Roger Hartle. How are you?
I'm well, thank you. Thanks for having me.
Thank you so much. Thanks for a very comprehensive presentation outlining really the evolution, your personal evolution, but also the evolution of the procedure, which is certainly, as you mentioned, very powerful, very important procedure that we use in MIS. Now, we talked a little bit about prone, and now let's say prone kind of takes off. Now we're just getting good at single stage lateral surgery, where we can address L5S1 in the lateral position and then do lateral approaches higher up, and then put in screws from the back, and even do decompression, from the back, all in a single stage procedure. So we're just kind of getting good at that and doing these procedures more and more, and very, very safely and very efficiently. Now with prone lateral, the obvious challenge then is to how to address L5S1. And as you mentioned, the more we know and learn about deformity principles, L5S1 really emerges as a very, very important level to treat, and you got to treat it the right way the first time around so you're not causing problems later on. So what are your thoughts if you at this point, I know it's early, but if you look at prone lateral versus lateral and the advantages of L5S1 axis-wise, the pros and cons for both, where do you see that going potentially?
Yeah, that's a great question to bring up because as you stated, we've obtained dramatic improvements by incorporating anterior lengthening at 5'1", right? Performing ACR at 5'1", and we can do so in the lateral position. and it's really not much of a stray from what we're doing. You know, a lot of folks are incorporating, the pre-psoas approach or OLIF when performing these procedures, and that can also be done in the lateral approach. And it's kind of funny. It took us a long time to get folks to put the patient in the lateral position. And now, a decade later, we finally got them there. We've got so many folks performing lateral, and now we're saying, all right, well, let's go back to prone. And, what you raise, the reason I think a lot of folks are trying to push, right? And a lot of it's coming from certain industry members is pushing for prone lateral is because a lot of folks are more comfortable. So even though that, all of you are incorporating lateral in your practices, still, I would say the majority of spine surgeons are not performing lateral access surgery. And, there needed to be some shift, some major paradigm shift to encourage others to begin to adopt, lateral access. And I think that's what the big push was, is, well, let's put it back in the prone position and get everybody comfortable, because that's how we're used to all training. And then we can get everyone to incorporate lateral, because now they're just in the prone position. So I think some of it is that and marketing. But I do think there is benefit. Not every deformity requires surgery down to the sacrum or the pelvis. There are certain instances where we're going down and stopping at L5. And one of the slides that I removed was the ISSG group showing that not every patient, that if you don't go to 5.1, if you don't have disease at 5.1, that you don't necessarily need to incorporate it into your construct, that you can actually stop at L5. So there are instances where perhaps not going down to 5.1 is okay, and you can do it in the prone procedure. Of course, you can do a T-lift from the back at 5.1, but we've seen the difficulty in obtaining the lordosis that you want to restore, right, that you can be capable of getting it at L5S1 in the lateral position. Although you have folks like Chris Shaffrey that are showing, 20 degrees of correction, down at 5.1, incorporating various techniques from the back. So again, we're all kind of still learning. The whole thing is still evolving, but I do think that there are folks that are going to like it in the prone position. When you guys did the lab, I'm not sure if you kind of experienced the difficulties that can arise simply related to the positioning. I mean, I used the word awkward numerous times as I was showing, as we were starting to perform it. Performing the procedure with your hands above you and moving things in the horizontal plane as opposed to in the vertical plane up and down. I feel like I have much more control of my instruments when I'm working vertically than when I'm working horizontally. I feel like I'm able to scrape that end plate and get that tactile feedback with the muscles that I'm used to using. And again, is this something that it's simply because I'm not used to it, or I'm just is it that it's actually not ideal? I think that's going to be something that plays itself out over time. But I do think it's interesting that we have Luis Pimenta, who is one of the primary innovators of this entire minimally invasive portal system, who is now really going prone, performing lateral in its prone position. However, he's also more aligned with a company now that is trying to push this and market this position. So I think it's going to play itself out over the next several years. I'm going to continue to employ it when I feel it's appropriate. What I learned is our first patient we performed it on had a BMI of 52, and that's not the right patient to start on. And it might not be the right patient to do it on, period, simply because working in that plane, in the prone position, a lot of things are popping out, and if you don't have gravity assisting you with the procedure, it makes it more difficult. And we found that when we were putting our shim in and performing the procedure, is that the shim is far more likely to pop out when you're inserting your other grafts, as opposed to when the patient's in the lateral position. So it's very early. It's in its infancy. We've got, I think, one paper out there on it at the moment, and it's just a technique paper. But it'll start to, I'm sure, as we continue to study it and employ it, we'll determine whether or not it's something that we're going to use more and more.
Adam, that was great. It was a great talk, very comprehensive. You touched on so many huge topics there. Very, very, very quickly. We could really spend a lot of time dissecting it all. But just to follow up on a couple of things you mentioned, the concept of praxias and stretching, you know, in the thoracic spine, we're so careful to shorten and be mindful of which way we're going with our correction. And in the lumbar spine, doing a lot of laterals, we really do, particularly with ACRs, we're really lengthening quite a bit. And I'm wondering if, in addition to the amount of time you have the retractor in and which side you go on, the concavity versus the convexity, and how much are we actually stretching? And you know, I don't see a lot published on it. I followed a lot of your work and some of the other guys are doing a lot of lateral, but just, you know, distal praxias, 4-5 weakness after doing multi-level lateral, oftentimes on the concavity. Any thoughts about how much you can lengthen or how much might be too much? You know, whether or not the plexus is scarred down or there's some, you know, adhesions to the osteophytes on that side. I've seen some of that, but I in my own patients, but I haven't seen a whole lot written on that. Do you have any thoughts about how much we can go and how much correction might be too much?
Yeah, you know, that's a great question. However, you know, that's something that regardless of how you're doing, you know, whether you're employing lateral or not, you know, something you have to be cognizant of as you're correcting these patients, you know, and you're converting a concavity, you know, into you know, a straight spine. But of course, when we're talking about incorporating these, you know, anterior lengthening procedures, you're more likely to put additional stretch. Now, we haven't seen a dramatic increase or really actually any significant increase in neuropraxia or stretch injuries since the incorporation of ACR. And it's now been, you know, over 5 years that we've been performing them. So I do think it's something you need to be cognizant of, but it's not something that we've seen play out in a clinical, you know, outcomes perspective, as in, you know, there being some dramatic increase in injury, you know, to the nerves. But I will tell you that as I'm, you know, working my way up the spine, you know, starting down at, you know, at 4-5, for example, in the lateral position, as I work my way up, I am thinking about that. It's something I'm constantly thinking as I'm performing the procedure and I'm you know, expanding, you know, the inner disc space. I remember when I first started doing these, I was amazed at how much we could open up the disc space. And I remember thinking, man, you can get 12s, you can get 14s in every one of these, and then every one of these disc spaces because it's such a powerful procedure. Of course, we also learned that you don't do that, right? Is that there's an appropriate size graft that you put in these patients, and that if you oversize them, then you can get not only stretch injuries, especially if you're doing it over 3, 4, 5 levels, but it's a dramatically different rehab process because the patients, it's much more difficult. So we might not be seeing it in neuropraxia as much as we're seeing that stretch present itself simply in the ability of the patients to recover, you know, because the nerves are needing to recover more. But we haven't seen it. We haven't seen what you're describing or suggesting, at least so far, you know, in the first 5 or 6 years of incorporating these ACR procedures. But it's definitely something to keep in mind. And again, keep in mind with any deformity correction, whether you're coming from lateral or not. You know, the main criticism of lateral access surgery and the primary reason for so few adopting it was because traditional surgeons would simply make the statement that, listen, you're going in on patients and you're performing these lateral surgeries, you're stretching nerves and you're, you know, causing these ipsilateral weaknesses, you know, and hip flexor weakness. And of course, if you're stretching the femoral nerve as well, you're getting, you know, knee extension weakness. So you're creating neurologic deficits by performing a deformity correction. And that's not something that we want to do. And again, learning that, you know, time and efficiency is critical in getting these cases these patients off the table. That's something that we've been able to, as we've gotten better at performing it ourselves and at training as well. We're finding that that's really the big difference in neuropraxias, and we're seeing patients being able to rehab much faster. So I didn't really answer your question because the answer is I haven't seen it, and I don't know if it's something that is going to present itself in time as we try and get fancier, you know, and do more through fewer, you know, shorter constructs and fewer interbody spaces. But it's possible. It's something we certainly should be cognizant of.
And one other thing, you mentioned a little bit about the location of the ACR, and it seems like 3-4 is the favored level for a variety of reasons, primarily anatomical. But you know, it seems like PSOs are somewhat moving more distal in the spine in terms of where it's most favorable, moving from L3, which even not that long ago seemed to be very, very favorable, and to 4, and now, you know, a lot of L5 PSOs. You know, listening to Lenke give a talk a couple weeks back about his L5 sandwich PSO technique, and it seems like ACRs don't really have that ability. We're not going to be able to move them down so much. But what about even 4-5? Have you attempted it there, or on select patients that may have favorable anatomy? I haven't seen too much with respect to moving it more distal, moving the location. Any thoughts? I saw you published a paper that shows there's really not any other complication with respect to PJK, but maybe for just making a more physiological or anatomically harmonious construct, just moving it lower.
Yeah, no, that's a great question and a great point, and one that we actually became, you know, wary of when we were wary of when we first started performing these, realizing that we're kind of creating lordosis in an unnatural spot, and there has been the trend towards doing these ACRs through the anterior, you know, while in the lateral position through the anterior approach, as Professor Hartle was describing. So we do favor actually performing the majority of our lordosis lower down. So at 4-5 and 5-1, 5-1 in particular, because we can get so much lordosis restoration at that level. So it's preferential. And so oftentimes now what we're doing is we're getting most of our lordosis in the lateral position through 4-5 and 5-1. And then as we proceed up, we're doing less posterior work. So oftentimes, in order to appreciate the full value of, you know, of a wedge-shaped, you know, a hyperlordotic graft, you have to perform more bony work in the back, right? As we were describing, you know, with the Schwab modifiers. So we're finding that we can put in more lordotic, hyperlordotic grafts higher up at say 3-4 or even 2-3, but do less bony work back there to have to cinch it down. So the majority, we do try to get distally. We are doing more and more to incorporate the lordosis lower down and less as we work our way up. So that's a trend that the, you know, minimally invasive surgeons are definitely aware of and incorporating into the practice.
In order to do that, you really have to do you have to get somehow pre-psoas, right? You can't do this all through the trans-psoas technique. You have to somehow release the ALL through either a second incision coming retroperitoneal from a more anterior or oblique approach, right? There's no real way to do that through a pure lateral trans-psoas approach.
Not yet.
Yeah.
No, it's definitely through the more anterior.
Great. Thanks, Adam.
Yeah, absolutely. Good questions. Thank you for that.
Thank you so much, Adam. Appreciate it. This is really, really a wonderful, comprehensive talk. And I think we could probably spend another 15 minutes at least asking questions, but thank you for your time. And we'll be posting this online. So if anyone has any questions, feel free to send them over.
Thanks, Adam.
All right, my pleasure, folks. Stay well, stay safe.
All right, take care.
Thank you.
Bye-bye.